Today we're going to be talking about hypertension. Let's start with causes. The thing that we have to exclude would be secondary hypertension. This would include things like renal disease, renal vascular disease, primary aldosteronism, obstructive sleep apnea, a pheochromocytoma, Cushing's, etc. Other things that could contribute would be a genetic predisposition to high blood pressure, a sedentary lifestyle, being overweight or obese, having an excess sodium intake, alcohol use, smoking, being in pain, or many different medicines. We would previously diagnose hypertension for those aged less than 60 as 140 over 90, or for those over 60 at 150 over 90. Our current guidelines don't have an age cutoff. Stage 1 hypertension would be diagnosed at 130 over 80 or above. Stage 2 hypertension would be diagnosed with 140 over 90 or above. Remember that this has to be done at least 2 different times on 2 different occasions. The first step is always lifestyle modification. The DASH diet, a low sodium diet or increasing potassium, increasing physical activity, weight loss, or smoking or alcohol cessation. When lifestyle modification alone isn't enough, then we have a number of agents which can help us. But where do we start? Step 1 is for individuals with CKD or microalbuminuria, as in an albumin to creatinine ratio greater than 30. For these individuals, an ACE or an ARB is first-line therapy. Previously, diabetics, regardless of presence or absence of albuminuria or microalbuminuria, would be assigned an ACE or an ARB. Now, guidelines dictate that we should wait till someone has microalbuminuria, an albumin to creatinine ratio greater than 30, for this to be the first agent. If an individual does not have CKD or microalbuminuria, and if the individual is African American, then a calcium channel blocker or thiazide diuretic would be first line. If an individual does not have CKD or microalbuminuria and is not African American, then we have a choice of a calcium channel blocker, a thiazide diuretic, or an ACE or an ARB. The calcium channel blockers are inexpensive and effective. They include amlodipine, felodipine, and nifedipine. Side effects include headache, lightheadedness, and commonly the dose-dependent peripheral edema. Thiazide diuretics are inexpensive and effective. They include chlorthalidone and HCTZ. Side effects include increased urination, so make sure you tell a patient before they start taking it at night, as well as electrolyte abnormalities, especially hypokalemia. This means that we have to regularly monitor electrolytes. The ACE inhibitors and ARBs are also frequently inexpensive and can pair well with calcium channel blockers and thiazide diuretics. We have a lot of examples. I've included a few. Side effects include the dry cough, more often with the ACE inhibitors, as well as hyperkalemia. The thing that we worry about would be angioedema. These also need to be monitored regularly.